Good. You want to start, Rohit?
Just a very good evening to all of you. I welcome all my panelist colleagues, Professor B.S. Singhal, Professor S.P. Godthi, Dr. Dheeraj Khurana, Dr. Arvind
Rohit, you're off.
Sir's connections is very
Netravati joined, Netravati joined. Good evening, Netravati. Netra. Hello.
Good evening, sir. Good evening, sir.
Great.
Sir, thanks a lot, sir.
Very, very punctual, I must say.
Netravati ma'am, you can start the session.
Yeah, Rohit, Dr. Rohit is there?
Sir facing some internet connection, ma'am, you can start.
Okay, perfect. I'll just give me 1 second. Dr. Sangeeta was supposed to come. I'll just ask her if she's coming. Just give me 1 second.
Yeah, Rohit's back.
Sir, you're muted. Rohit, sir, you're muted. Yeah, sorry. I think something went wrong with my connection abruptly. I don't know why. So I welcome everyone, and on occasion of World MS Day, we felt prudent that it is good to connect with our patients and doctors and neurologists across the country to share views from our panelists for some important concepts and questions that may be of importance to all of us. With this small welcome, I now hand over to my colleague, Dr. Netravati, to continue the session, please. Dr. Netra, are you there?
Yeah. I'm just trying to unmute.
Okay.
Very good evening, everyone. At the outset, thank the Indian Academy of Neurology, Autoimmune Subsection for giving us this opportunity. So this webinar has been organized on behalf of World MS Day, which was on May 30th. So we'll be having a panel discussion, and we'll be taking a few questions. And after that, we'll also try to address any questions from the attendees. If it's there, we request them to post in the chat box so that it can be taken by the panelists. So over to you, Dr. Rohit. Thank you.
I would now request Professor B.S. Singhal to kindly talk about why having this webinar and what is the importance of the World MS Day and how it shapes our future about understanding of MS in general and the possibilities and the frontiers that it has in the future.
Thank you, Rohit. Thank you, Netra. And thank you, all the panelists. And also I think the MS warriors and the caregivers are also probably attending this important World MS Day, which is celebrated on 30th of May, the world over. I think main objectives are really to increase the global awareness, promoting early diagnosis and care, and I think to have a panel discussion so that the more information is passed on. And of course, it unites the whole MS community. As you know, there's also, apart from the MSSI, there's also the International Bureau of Multiple Sclerosis. They had a meeting in Delhi as well. And of course, we want government officials, institutions, policymakers to give more resources for MS research. And I do hope that some of the insurance people are listening so that they can make the drugs more affordable for the patients so that they can start the treatment early on. it also inspires hope and resilience amongst the people, and also encourages research and funding. And I'm very, very pleased that Rohit took the initiative, and all his colleagues have started the MS registry, which we hope will give us more direction about how our patients are behaving and with the various drugs, So I think the importance of the World MS Day is really to increase the awareness and provide all the new researches that are going on. So I think we have the panelists today who will be answering the questions. So thank you very much, Rohit, and thank you, Netra, for arranging this meeting on behalf of the IAN subsection for the immune disorders. And we have very good panelists here today. So I'll be only one of the persons listening to it. Thank you very much. Netra, please go ahead. So Rohit, you take over Netra. I don't know. She not lost touch with them.
I don't know. She's there only. Okay, I think there may be she may be in the process of joining. So, Dheeraj, I'll start with you, and to kick off the discussion, could you please, start by telling about MS in general? What is it? What are the clinical features so that it helps people understand it better?
Sure, Rohit. Thank you. And hello, everyone, especially to the MS warriors who are joining us today. So practically, MS, as the name suggests, it's multiple and sclerosis. It is a disease which affects the central nervous system, mainly the brain and the spinal cord, any part of the brain and spinal cord. And as the name suggests, it can affect multiple areas, which could be commonly the eyes, any part of your body which is controlled by the brain, or any part which is controlled by your spinal cord. And multiple also suggests multiple times. So this is how MS comes. It comes in form of attacks. And these attacks can sometimes be disabling, but mostly they are non-disabling. They may be mild. You may have blurring of vision of one side, and you may have weakness of one side. You may even have slurring of speech. And usually the symptoms, they slowly progress. You may have a subtle onset, progresses over a few days. It may become static. And then the symptoms may be self-limiting sometimes, and people may ignore it. And this is the most important thing that we emphasize, that if any of these symptoms ever afflict anybody you know, anybody around you who has either a blurring of vision, numbness of the body, one part of the body, which lasts for more than 24 hours or a day or a few days, even if it tends to recover after a few days, could be suggestive of a MS-like illness. Now, what is MS? Now, why do these happen? Is primarily, we all know that this is called a demyelinating disorder. So what is a demyelinating disorder? Is basically there's a covering of all the nerve cells in the brain called the myelin. It is like the insulation around your electrical wires. And somehow the immune system in our body gets deranged, and the covering gets damaged because of attack by our own immune cells. And there is a certain threshold, this may be going on for years. One may ask, why does it happen on one fine day? No, that doesn't happen. Sometimes this may be present for many years, and there may be subclinical or minor damages happening in your brain, which one day gets crossed over what we call as a brain reserve. And that brain reserve threshold is crossed over, and you might get an attack. So sometimes, so we occasionally even pick up multiple sclerosis like illness on routine MRI imaging for something which is not indicated. Like, for example, we get it for a routine headache, and you might get the MRI changes of plaques on the MRI, which now we know that they may be harbingers of predictive disease of MS. So important to know is MS can affect any part of the brain or the spinal cord. So any part of the body can have symptoms, like I said, eyes commonly, and also the paralysis of your limbs or your arms, and it may happen multiple times in terms of attacks. And that's why we call it relapsing and remitting. Means it happens multiple times and it gets better multiple times. But important part is we need to diagnose it early as possible, because there is very huge amount of evidence now that early treatment is mandatory, not just because it saves disability, but now the newer treatments which are coming up can also prevent an invisible kind of a damage which we see later in life in MS. So this is very important to understand these symptoms and why medical help should be sought, and you should seek help from a neurologist. Thank you.
Thank you very much, Dheeraj. Dr. Gorthi, could you enumerate? A lot of people have this question in the clinic. Doctor, please tell us why we had this disease and what could be the reasons, and if there is any reason that could be specifically attributed to and controlled. So could you enumerate, what potential reasons have been thought of in the causation pathway or occurrence of MS?
Thank you, Rohit. And see, while the exact cause remains unclear about what caused this, but research points to a combination of genetic, environmental, and immunological factors. There is already told about immune dysregulation, which can be because of viral infections and many other things. So, which I'll touch one upon. Actually, what is felt is that it's an interplay of genetic, environmental, and immunological factors. And for the common public, it should be said that we are still not clear about what caused. But one thing is certain, that is genetic predisposition is there in the, especially with the human leukocyte antigen system, which will predispose to this disease. And next important thing which we know is that Epstein-Barr virus infection, which may lead to in the genetically predisposed individuals to this particular disease. And third factor is what we usually say is vitamin D deficiency. And fourth is smoking. So there are some studies which are called cohort studies or case control studies, but there are no randomized controlled trials to say that what has caused this malady, which is autoimmune in nature, which is characterized by inflammation as well as demyelination and neurodegeneration. So all these three aspects can be related to some other factors like childhood obesity, and high body mass index in the childhood is supposed to lead to MS. And also smoking. Smoking is another important factor. And recently we have been studying gut microbiota or gut dysbiosis, which is also leading to multiple sclerosis. So exactly what is causing is not known, but the basic pathophysiology of inflammation, demyelination, and neurodegeneration can be linked to various other infections. Other infectious agents like herpes zoster infection in the body, etc., can cause, and not very. But more importantly, geographic latitude and sun exposure. Now, it's supposed to be higher MS prevalence is observed in regions with less sunlight, suggesting a connection with vitamin D levels. Chronic stress also may exacerbate MS by eliminating immune function, and environmental toxins. And hypothetical to there are many which are, but the evidence is very weak about this. So in summary, what we can say is that MS etiology involves a complex interplay of genetic, environmental, and immunological factors. Stronger evidence supporting genetic, Epstein-Barr virus, vitamin D, smoking as significant contributors to this problem. And it's more seen in the at where there is colder climates and where there is less sunlight, suggesting again a role for vitamin D deficiency. And these are one of these concepts that are recent and supported by class 2 and class 3 studies, but there are no class 1 evidence to say that. Thank you.
Thank you, Dr. Gorthi. Very well said. I think it's a complex interplay of many factors, not one which is absolutely known. And of course, there is a noise about Epstein-Barr virus, it's smoking, and of course, some inherent potential markers of genetics that may be playing a complex interplay to happen, but we still don't know the exact reason and the cause. So, Dr. Netravati has joined us, and I will just ask her to talk about generally what happens that patients get worried on hearing the diagnosis, and we obviously need to address that concern, that to obey the concern. So, Dr. Netra, could you just talk about, whether it is something that should be really causing a panic, or we should take it the way we take it many other disorders. Could you just speak about that a bit, please?
Yeah. Thank you, Dr. Rohit. So most of the time, what happens is when a person is diagnosed with multiple sclerosis, the first concern they have is about denial. Just like any other illness, denial is the first thing which happens. So usually we take it as a stepped procedure. That means in the first instance, when we come with contact with the patient, it becomes difficult for us to completely tell everything about the illness. So there's always a stage-wise procedure what we take. One thing is that, and then we try to tell them the positiveness of the problem. Like, for example, most of the time when they are diagnosed, the first thing is it curable? Is their first concern which comes up. So I always reiterate that more than curable, the next to cure is something which can be controlled. For example, many years back, there were no medications or very less medications which could control the illness. So now the science is advanced to such an extent that we are able to control the illness with proper medication. And also, I stress upon that once you become better, what happens is that you become better and you start procrastinating and do not take the medications and continue the disease modifying agents. So stress about continuing the medications so that the continuity is there. They'll be able to control the illness. They'll be able to hold into the illness in the initial stage of inflammation and see to it that it does not go into the degenerative phase. And that is a paramount importance. And of course, compliance and adherence. I think those things are very important. Previously, there were medications which were almost either daily injections or alternate day injections. So that would worsen the compliance as well as adherence. But now we do not have such things. So stress upon the compliance, stress upon the adherence, and also about whatever problems are there. What happens is patient may have come to us with vision problem or a walking disability. So we should also make a point to address a lot of the invisible symptoms which could be there in people with MS. So stress upon that in all their subsequent visits so that it is addressed. So basically, what I would want to stress and eventually is that we have treatment for this disorder and it should be continued and not to stop the treatment. Thank you. So one of the thing is about the medications. So once we have addressed that we are going to start them on medications, most of them are apprehensive about the treatment. Dr. Ayush, I just want to know from you, what do you think? How do you discuss? What are the possible medications which are there for people with MS? And how do you discuss that? Over to you, Dr. Ayush.
Thank you, ma'am. The treatment discussion is usually based on what I've learned from Rohit sir and Professor Padma, who are my teachers. So we usually tell them about the pros and cons of all the treatment options that are available. And with the grace of God, we've been able to discover more and more drugs. So unlike the 90s when there were very few options, now we've got a whole gamut of drugs to choose from. And what we usually do is that depends on the symptoms of the patient. If the patient is having mild symptoms, something that is not very disabling, we start with drugs that are effective and side effects are relatively very few. Whereas if somebody is presented with an aggressive disease, we usually go for an injectable monoclonal antibody because we want rapid effect, although there may be some side effects which we explain to the patient. So the decision to go slow and gradually escalate if required versus directly being very aggressive predominantly depends on the symptoms of the patient and also depends on the choice of the patient, because there are some people who are very high achieving individuals who do not want to risk another relapse and they're okay with taking the risks that are associated with the monoclonal antibodies, versus some people who are very apprehensive about being very profoundly immunosuppressed, that we would rather chance another attack, but we want something that is relatively side effect free. So the decision to choose a drug is always based on detailed discussion with both the patient and the caregiver. And thereafter, after deciding the pros and cons of the drug that the patient is choosing from, that is how we usually start a DMT in patients of MS at our center.
Thank you, Dr. Ayush. You nicely brought about the available medications which are there and about the efficacy and how it has to be tailored. Dr. Dheeraj, how do you address this treatment aspect? Like, for example, when the patients come to us with initial diagnosis, they would have sometimes gone to multiple doctors. So how do you decide upon the treatment aspect? And which treatment do you think? Is it like one size fits all, or how is it? Can you kindly elaborate on this?
So I think Ayush did mention about a certain aspects of the treatment. So I would just add on to that and basically complement to what he said. Is basically the decisions depend upon a number of things. Now that we know we are moving towards the philosophy, or we are moving towards the age of personalized medicine now, and so one size fits all has to go off. The entire world of medicine is moving very gradually, but definitely towards a personalized medicine. So here also we try to look at a personalized medicine aspect. However, I have a slightly different view in terms of giving treatment of escalating versus induction. I'm a big proponent of induction, and that's not just my own personal view, but it's all a result, or I would say secondary to the evidence that has been generated over these number of years. In the past, we've seen multiple high-class evidence of meta-analysis, systematic reviews, and real-world evidence, which suggests that be it any kind of MS. Earlier, we used to say, okay, if we have a very high active MS, something which is behaving erratically, errantly, number of episodes happening in the first year. Now we know that even if you're having an attack infrequently, there's things which are aggressive in the background. What we had a recent discussion to the smoldering MS. We know of what is smoldering MS is nothing but those silent episodes which are happening, and these episodes what we are now calling as PIRA and all. So we need to stop that, and one of the only ways we can probably curtail it in the current time till we don't have effective progression curtailing medicines is to hit hard right in the beginning. So I would suggest for most of my patients in general to start with stronger medications, although these strong medications are safe. For example, rituximab, which is very suitable for our population, being low cost. And then you have Ocrevus or ofatumumab, which is also available, or natalizumab. So these all options are available as high efficacy and relatively quite safe. All the side effects, we usually discuss side effects and what kind of expected side effects, and the patients anyways are MS people, they all are anyways inquisitive of how these drugs would act since they are stronger drugs. And later on, the plan is to shift them to milder or low efficacy treatments. And that also is what we de-escalate these. But coming back to the specific scenarios, so if we have, for example, and this gets more, I would say, heightened our plan to give stronger treatments if there are MS which is associated with worse prognosis. For example, if it is a male patient, it's an elderly patient, I mean to say MS which has started late in life, and of course which is aggressive. So these become all the more important that we offer them a high efficacy or a stronger treatment in the beginning. And then also looking at scenarios, people who are working, for example, if they are working, they're going to work, what would be the best form of treatment? Would they be comfortable? So we have a shared decision making kind of I would say, the shared decision making platform that we have, where we talk to them, we discuss with them what would be most appropriate. And it so happens that people who are more comfortable injecting themselves, they may choose a self-injecting treatment like even interferons. But like I said, if they just want to go for interferon, we do have now high efficacy treatments like ofatumumab if they can afford it. And pregnancy. So maybe you'll be discussing pregnancy later, so I want to discuss it now. But we need to look at scenarios of the patient and then take a call on the treatments of that according to that.
Thank you, Dr. Dheeraj. You nicely brought about the efficacy and about tailoring it to the patient based on their clinical as well as their radiological and even on the gender aspect. So one of the things is whenever we diagnose multiple sclerosis, one of the most important investigation is doing a MRI, and then we do start treatment. And the initial guidelines were about doing an annual MRI. Dr. Ganraj, this question is to you about what do you think about what should be done, whether annual MRI is required or is there any other frequency to be done? Over to you, Dr. Ganraj.
Thank you, ma'am. So, as it's already, we know that MRI is one of the important thing for the diagnosis of multiple sclerosis. And in addition to that, it also acts as a valuable tool for knowing the follow-up of these patients, especially if they have any new lesions in the brain, or to see how severe is the disease activity, how lesion loads are there, and also for switching the medications. So, doing a MRI in the follow-up is based on the multiple factors, whether the how is the disease and how severe it is, what is the type, whether it is a progressive form or whether it's a relapsing remitting form, and also if the patient has any relapses or any new symptoms during the follow-up, or to know how efficacy or how the medicines are working in the patients with multiple sclerosis. So, clinically, patients can have some symptoms. So, MRI will help us in identifying subclinical symptoms and also to know the treatment response. So, it is one of the important thing which is helpful for knowing the follow-up of these patients. So, in case of any stable patients, if they are not having any relapse and no other new symptoms, no side effects to the medication, they are maintaining well, and MRI can be done maybe after 1 year or after 1 to 2 years based on the clinical severity. However, in case if any patients have any new relapses or if we have started some new medicines and they are noticing some side effects or to see how the medicines are working, maybe we'll have to do after 6 months of initiating the new therapy where the patients were not responding. So generally from about 6 months to 2 years, based on the clinical condition and the type of the illness and side effects to the medications, maybe MRI is required from about 6 months to 2 years, and also by the physician who is following the patient will decide on this follow-up MRIs.
Thank you, Dr. Ganraj. So usually what we do is after the diagnosis is done, if the symptoms have improved annual, at least for the initial few years, and after that, only if they develop any new symptoms, then we do the MRI, or if we are planning to change the medications also, we plan to do the MRI. Coming to the annual monitoring of MRI, Dr. Gorti, sir, the question is to you. So if someone has a MRI activity, like for example, patient comes to you with their annual MRI and you find that the MRI is showing some new lesions or a enhancement, what do you do? What do you discuss with the patient?
Thank you, Dr. Nitra. And see, the decision to change the DMT is a multifaceted one. We have to integrate the MRI findings with the clinical status of the patient. And there may be some patient-specific factors also, whether he's RRMS or primary progressive MS, also treatment context. There are some recommendations from the recent literature, and which we can say that mainly there are three. It depends on Magnin study group. If after 1 year, if more than 3 new T2 lesions, especially with relapses, the enlarging lesions, it is indicate an increased risk of treatment failure, and also suggests that EDSS may worsen over the coming 3 years. So you have to do. The other one which follows is a RIO score, and where if after 1 year more than 2 new T2 lesions are there, and also combined with more than 2 of the 3 criteria of the RIO score, that is relapses, EDSS progression and MRI activity, they suggest a high probability of a relapse. So in that case also we have to change them. Then we have a modified Rio score, which is refined at 6 months post 1 year, more than 4 new T2 lesions. So it all depends on what on MRI is showing, but that's not the only thing. If a patient is stable, as Dr. Dhanraj said, and we don't have to chase the MRI. If patient is not stable and is developing a progression of the disease and more relapses, then we may have to say that. So the context what we say is MRI activity alone may not warrant an immediate change of the treatment if patient is clinically stable with no relapses and stable EDSS. However, subclinical MRI activity predicts future relapses and progression. That's why we do the follow-up MRIs, and if there is the lesion load is increasing and more than 3 or 4 T2 lesions and enlarging lesions, then we may think of that. There are some recommendations from ECTRIMS and AN 2018 that switching of therapies is definitely recommended if there is a breakthrough disease develops, both MRI wise as well as clinical wise. So the baseline activity also dictates if there are more than 10 lesions in the start T2 lesions, then it's going to be a very stormy course, and we have to clearly follow them up. And if patients are only on the low efficacy treatment like interferons and glatiramer, then after 6 months you do a follow-up MRI, and if there are new T2 lesions or enlarging lesions, then we may have to switch over to other type of aggressive treatment like natalizumab or ocrelizumab nowadays. So that's another one which we have to keep in mind. The baseline activity and early follow-up is recommended for when the individuals are on the low efficacy treatment. And when they are on high efficacy treatment also, we have to be wary of infections like PML. And so a follow-up MRI will definitely help in the routine monitoring of these cases. So if we can summarize saying that MRI disease activities such as T2 or GAD lesions signals potential treatment failure that suggests inflammation and breakdown of blood-brain barrier, especially more than 3 T2 lesions and more than 1 GAD lesion appear within 6 to 12 months of starting a disease-modifying therapy, or if persistent activity occurs later also. So the decision to change treatment hinges on these MRI integration with clinical relapses, disability, and patient factors. Early in treatment, obtain a baseline MRI at 3 to 6 months, then monitor annually, as we had a debate recently with Dr. Ichapuria when we debated the other side. But annual MRI is recommended when this is active. This is very active, and change medications urgently is required if there is a significant combined clinical and MRI activity or safety concerns like PML. Otherwise, a rescan in these cases from 3 to 6 months to confirm the trends. So high quality MRI, Dr. Shingal was saying that MRI has to be standardized, and the standard protocols a minimum 1.5 Tesla, and nowadays the central vein sign and paramagnetic rim lesions are also. So there are new things that are coming in the MRI to help us to say whether inflammatory activity is going on or not. So these are things which the radiologists also should become aware, and the new type of MRI techniques and which are available or to be applied. So I think the treatment of dependent on MRI has been evolving over centuries now. Ever since Shoemaker has started the diagnostic criteria, and Poser, depending on MRI, has brought in some lab associated criteria along with MRI. And McDonald himself has revised 5-6 times, and these criteria get revised with the help of magnims. So it is ever changing field, MRI. So we have to depend not only on MRI, but also on clinical response as well as EDSS progression to decide a therapeutic change. Thank you, Dr. Netra.
Thank you, sir. So you brought about very nicely about how do we actually, you covered almost both the clinical and the radiological aspects as to how we should be monitoring and what are the newer things which has come up in radiological aspects of multiple sclerosis, how to monitor, how to find out the inflammation, and so on. So we don't have Dr. Pujari today because he's unwell. I would request Dr. Singhal sir if we can address this question about what are the decisions we take? Like the person is taking a disease modifying agent, and when do we talk to them about switching therapy? And the other thing is about most of them ask that whether we can take medications for few years and then stop it, discontinuation of medications. Sir, if you can just shed light on these, sir.
No, I think you asked a very good question, but I think Dr. Goti has really summed up very well as to when to switch the therapy in case you are starting with low efficacy therapies. So I think, he has given all of the modifier Rio score and also the lesions in the brain and also the clinical relapses. I think he has very adequately covered it. As regards discontinuation of the treatment, I have a feeling that they haven't got any, I think the treatment practically lifelong, but they are reviewing it. And I think if the person remains very stable, perhaps after the age of 60 years or so, you might consider, stepping down the treatment and even discontinuing. But I think it's a decision based individually. There are no general guideline on that. If I may be mistaken because I'm not very well aware of the later literature. Rohit, you have any view on this? Discontinuation of treatment.
So actually, there have been observation studies and people have looked at discontinuation rates among patients with MS. And in fact, there was one of the recent papers on that also. But honestly speaking, I think currently as we are in the world of MS immunology, we generally do not recommend stopping the drugs, and we would guide and counsel the patients that they should continue medications. We have good monitoring systems. Drugs have shown to have efficacy and safety long term. Yes, there is always a potential concern when we're using biological agents because we really don't have extremely long term data, but at least for the drugs that have been used for a long time since past, we do have fair amount of data of their safety, including data of natalizumab, data of rituximab from a lot of observational studies. And as time will elapse, we would have more data for other drugs like ocrelizumab, alemtuzumab, and ofatumumab, and so on. And there will be new drugs that will keep on coming, and there will also be guidelines which will progressively getting updated if there are adverse effects, and monitoring systems which are adaptable and found that they should be done for patients. So I think as of now, there are no strong recommendations to withdraw agents in stable disease. And I think we would encourage all patients to continue the medications.
That's right. Here I might add, many of our patients discontinue on their own.
Yeah, of course.
Point, sir.
So here I think Rohit, your registry will be very useful.
Thank you, Dr. Singhal sir and Dr. Rohit. Hello.
Go ahead.
Yeah,
Go ahead. I think you are muted, Netrapati.
Sir, you were telling something, sir. So I just
Nothing. No. I think I'm just saying that you go ahead, please.
Sir, there is one study, sir, which said that after 55 years and 5 years disease free, there are recommendations that one may, otherwise people will get disappointed. How long we are going to take these medicines? So at least to brighten their hope and not to contradict Rohit, but there is a study which is a 5-year follow-up after 55 years and which said that one can stop. So there may be more studies.
We'll have to, wait for more studies and probably world experience. I think the MS-based and such data all over will provide some answers. And maybe registry of Rohit also will be very useful. Good. Go ahead, Netra.
Yeah. Thank you, sir. I think what you stressed about the registry being maintained is very important. I think we'll bring up that in the end so that Dr. Rohit can talk about the registry. So one thing is it is sometimes if they're planning for family, that is the time we may discontinue for a very transient period of time. That's the only time when we try to discontinue. Like what Dr. Gorti said about after 55 years, there have been few studies which have told postmenopausal also we can try. But of course, the relapse, if it happens after that, could be more bad, especially in elderly population. So we need to be careful about that also. Um, uh, Dr. Ganraj, if you can just cover a few aspects. We've been talking so much on MS. We spoke on multiple sclerosis, disease modifying agents. So if you can just talk about the progressive form of multiple sclerosis. Over to you, Dr. Ganraj.
Yes, this is also one of the subtype of the multiple sclerosis where we see relapsing, remitting, and the progressive form. And this subgroup is a bit not so responsive to the medication. So, although there are many medications which have come up for the treatment of this progressive form of MS, still it needs a lot of research and clinical trials, especially in this aspect. In addition to that, not only the medical therapy, the symptomatic therapy, especially if the patient has stiffness or tiredness or any constipation, these symptoms also add to the overall the clinical burden, which they feel that they may not be so responsive to the medication. So it is not only that they are taking the medical therapy. In addition to that, it needs symptomatic management with antispastic medications and controlling their moods, mood stabilizers, antidepressants, and constipation management and rehabilitation, physiotherapy, occupational therapy. This also plays an important role. In addition to that, sometimes lifestyle modifications like cessation of smoking and yoga therapies are also known to be having beneficial role in the management of this progressive MS.
Thank you. Thank you, Dr. Ganraj. So progressive MS is one thing where the available options of medications are less. It's a degenerative form of MS. So sometimes RRMS progresses into progressive form of multiple sclerosis. And it is better to have the treatment during the RRMS stage so that we control the illness better and prevent the progression happening. And the available treatment options are very less in the progressive phase. So among all,
Just
we
one more
discussed
additional,
about
if I could add here, Netravati,
yeah,
is
yeah.
the new drugs, which are still under trial. So we just had a recent results of the tolebrutinib study in non-relapsing SPMS. So just the only reason I'm mentioning here is these are clinical trials which are ongoing, and we should encourage all our MS warriors to participate in these trials because they are very encouraging results. For example, with the first BDKI, which has been tested, the tolebrutinib has shown very, I would say, strong effect on progression, almost a 8% absolute reduction in chances of having progression in patients on tolebrutinib. So these trials are going all over the country, and patients who are in touch with physicians who are, doing trials in SPMS, they should there should be more participation because we feel that there is going to be a good effect of PTKIs. That's the only reason I wanted to add this.
Thank you, Dr. Dheeraj. I think it's an important thing. The other thing which has come up recently is also about the use of vitamin D. I think you brought about last time in another panel discussion about the vitamin D. If you can just stress on that also, because I think that is one thing which is not very much stressed about the treatment.
Yeah, definitely. Vitamin D should never ever be missed. In fact, very initially there have been multiple conflicting evidence coming for vitamin D, but very recently this huge mega study on real world population which looked at vitamin D levels and vitamin D supplementation, although that was at a higher degree of supplementation. It's more than what we give as 60,000 units per month. It was, I think, a bit more than that. I'm not really sure. A little bit more than this, what we are giving. But it clearly showed that people who had the first stage of MS, which is CIS, clinically isolated syndrome, there was clearly a delay in the people who had supplementation of vitamin D into established RRMS. So that kind of indicates that there is some effect on activity, and we should not stop giving vitamin D. We should keep encouraging. This is one thing which is safe, efficacious, and not very high cost. So vitamin D should continue at all costs, and we never stop that at any stage of MS. There is definitely an effect, and we have been getting evidence on this.
Thank you, Dr. Dheeraj. I think that's one of the most important thing, which is very less cost compared to other disease modifying agents, which is there. And we need to emphasize about the usage of vitamin D, and even in the monitoring, when we are trying to get their blood levels, vitamin D evaluation should go into the treatment paradigm. Thank you, Dr. Dheeraj. Uh, Among the clinical symptoms of multiple sclerosis, we know about a lot of optic neuritis, spinal cord involvement. Another thing which is very much disabling to the patients is about the involvement of bowel and bladder. So when people have bowel bladder dysfunction, how do you address it? Dr. Ayush, if you can just take up this question on.
Uh, Thank you, ma'am. So the bladder dysfunction, as you correctly said, is a very disabling symptom for patients with multiple sclerosis. However, there is no one-size-fits-all treatment for that because the bladder dysfunction differs according to the location of the lesion of multiple sclerosis. Usually, we find that patients complain that they are unable to hold urine as soon as they have the urge to pass urine. They immediately have to go to the washroom. Otherwise, they are unable to hold it and sometimes complain of urgency and occasionally even urge incontinence. So, in such a situation, we usually give a drug that will help relax the bladder a little more because the bladder seems to be a little hyperactive. And these drugs usually lead to good symptomatic improvement. Initially, we had a few anticholinergics that were available, but now more and more drugs that act at the level of the urinary bladder have been found and are being used with very few side effects and very good symptomatic improvement. However, we also encourage people who have severe bladder issues to undergo routine ultrasounds because we sometimes find that the amount of urine that is retained is much more than there should be. And in such a situation, we usually then advise them to learn clean intermittent catheterization so as to prevent the occurrence of frequent urinary tract infections that can otherwise occur. And finally, what is sometimes seen is that if the lower part of the spinal cord is involved because of multiple sclerosis, patients complain of inability to void. They say that they feel that the bladder is full, but they're unable to contract, in which case we give them the opposite, that is drugs that help contract the bladder. So the treatment for bladder issues depends on the symptoms of the bladder that the patient is suffering from. And thereafter, depending on the severity that the patient has, we either give drugs or we advise them to learn clean intermittent catheterization so that they don't have these issues.
Thank you, Ayush. I think it's important that not all people with multiple sclerosis will have same type of bladder issues. Most of the time, they need to undergo testing, sometimes a urodynamic testing to assess the type of bladder, and sometimes there could be a mixed type of bladder. And it is important to assess after the urodynamic assessment and start specific treatment. The other thing is about the urine infections, which can cause transient urinary symptoms, and just addressing the UTI may sometimes help in controlling the bladder issues. Thank you, Dr. Ayush. I think the most important thing, especially because MS is something which affects the middle-aged and more common in females, it is about the pregnancy and family. This question is to Dr. Dheeraj. If you can just bring light upon how do you address the issues about pregnancy management and family therapy in people with multiple sclerosis.
I think this is one of the most, I would say, center stage in MS questions around how to, start a family, how to deal with pregnancy, because this is going to be majority of our patients. The the biggest chunk of our MS warriors are young women who usually present to us in their early 20s, late 20s or early 30s, or sometimes even before 20. And the biggest concern at all points of time, as soon as we discuss treatments, is the concern of the parents or the MS patient himself or herself, is how their future is going to be. Will they be able to live a normal life? So firstly, I would say, before we deal or before we embark on the stage of discussion about how to deal with pregnancy, we need to reiterate the fact to all our MS warriors that they can completely live a normal, healthy life as a normal individual. That is the first important aspect of MS and what we have achieved in the current era over all these years, the progress that has happened and our understanding of MS, that they can completely lead a normal life. Now, coming to the aspect of how to plan a pregnancy. So there were times when we never had safer medications, and pregnancy was kind of very considered to be a difficult thing to manage in MS. But over the years, a lot of evidence has been gathered, and we know that there are safe medications which can be used. The safest ones, of course, are if somebody has that kind of a illness where treatment needs to be continued during the pregnancy. One of the safest medications is interferon or glatamer. Glatamer is not available currently in India, but interferon is. So interferon can be safely carried even during pregnancy. Now, the issue is going to be we are going to be facing is people who are who are already on oral medications, the commonest oral medications being DMF, the dimethyl fumarate, or teriflunomide. So we need to tell our patients that when we start teriflunomide, that's a strict no-no. We all are aware of that. Teriflunomide, you cannot have a pregnancy, and either we wash it out or we don't start it. So that's one thing we need to tell our patients, that if on teriflunomide, do not even plan to conceive. With DMF, the policy followed is, if they are on DMF, they can conceive, but as soon as they know they have conceived, they should stop the DMF. Now, that's the usual dictum which is being followed. And if, as is the usual case, people are on the injectables like natalizumab or ocrelizumab or rituximab, anti-CD20s. So for natalizumab, again, the registry data which has come up till date just tells us that if people have, in fact, conceived while being on natalizumab, we should stop and not give the subsequent dose. So the pregnancies have mostly been normal pregnancies, and a very small, the comparison with the normal population, the harmful effects of natalizumab were not seen, especially if it was stopped as soon as conception took place. So we do not advise natalizumab to be continued, but to stop as soon as possible, or preferably if it's a planned pregnancy, then they should stop natalizumab and then plan a pregnancy. But just in case a conception happens, then they can stop natalizumab. And the results have shown that there are no, and we've had a couple of patients on natalizumab who conceived, they've had normal pregnancies and normal children. So coming to the most common thing, which is rituximab or natalizumab, rituxi or Ocrevus, we in fact suggest people who have high activity disease to switch to anti-CD20, because that's considered to be one very good method of tiding over the period of pregnancy. And that usually what can be planned is patients can be given a first dose of rituximab, and then if they plan a pregnancy, which can be done 2 or 3 months after the last dose of rituximab, and then they can tide over the period of pregnancy, because the effects of these medications invariably last from 6 months to 8 months. We know that, and we can look at anti-CD20. So the rituximab or anti-CD20 drugs, which is the 6-monthly ones especially, can be one option for high activity disease, where the conception can be planned at least 3 months after the last dose. So that has been considered relatively safe. The ideal, if we read the papers which are available to us from the lymphoma papers, lymphoma evidence, they usually state that after the last 6 months of rituximab, it's safe. But number of studies have shown that even if the pregnancy is continued or conceived 2 to 3 months later, and people even have been given last trimester doses, and that's from the data from lymphoma, and that has not really harmed the fetus, because what we are really dealing with low B cells in the fetus. So usually, and we also know that in pregnancy, the chances of relapses are low. So during that period, a good opportunity which we have is low chance of relapse, And if the patient is on a high efficacy treatment, you could continue with a single dose of rituximab. But then what is recommended is, as soon as the delivery is done, they should take the next dose as soon as possible for either the anti-CD20 or whatever treatment is being given, because that is again considered to be safe. We don't have many harms, significant harms in breastfeeding with anti-CD20, but the rest of the drugs we do have, the orals, for example. So anti-CD20 may actually be reinstituted post-delivery, and that 6 to 9 month period can be tided over with one single dose of, say, rituximab or Ocrevus. So that's a usual norm which we follow even practically in our practice.
Thank you, Dr. Dheeraj. I think that's the most important question, especially when a person is trying to tide over the family, and also try to see that they do not have any of the chemical in their body. You nicely brought about how we can tide over with the medications and what are the medications which have to be avoided if you're planning for pregnancy. Thank you. I think we will be having audience questions. Before that, one of the treatment aspect is about stem cell therapy. And Dr. Rohit has a lot of experience in that. Dr. Rohit, this question is to you about when do you suggest a person to undergo stem cell therapy, and where does it stand in the treatment paradigm of multiple sclerosis?
Thank you, Netra. I think just a quick background on it is that it is definitely one of the important and appropriate strategies now in the care pathway for multiple sclerosis, but as a part of an escalation strategy, like we've discussed, moving from one DMT to the other, and if it is not working, in the same paradigm. If you talk about the broad concept, it is generally seen to be a favorable treatment escalation for patients with relapsing remitting MS, people with relatively low EDSS score or a relatively low disability, disease duration, which is generally considered lesser than 8 to 10 years, and a younger age group, which is generally below, on an average, considered to be 45, which is based on general recommendations of the ACTRIMS and the Bone Marrow Transplant European Society, which was even recently brought out in a very leading journal. So if you have an MS which is of relatively not a long duration, you are not that disabled, and you have relapsing remitting MS, you're a younger patient, but you have relapsing remitting MS which is not stopping in spite of taking at least one highly effective treatment, which includes one of the monoclonal antibodies or drugs that are considered to be effective, or if you have taken a medium efficacy drug along with a highly effective drug, you can be potentially screened and considered as a shared decision making for consideration of autologous hematopoietic stem cell transplant. If you have an aggressive disease from the beginning, and you are going to talk about it as an upfront treatment, that is currently not really recommended out of context of a trial or context of an ongoing study in a center that is collecting information methodically on these patients with a very controlled system of doing a bone marrow transplant. So there it is always prudent to first start with a highly effective drug and then see your response, because you may do as good as a bone marrow transplant. For progressive MS, if you have a relatively early progressive MS and your physician has picked up that you are slowly transitioning and you're not benefiting with a drug that is presumed to be benefiting a progressive MS, like let's say one of the monoclonal antibodies, but you have a active disease either in form of relapse or your MRI showing more disease activity, which means new lesions or larger lesions of your previously accumulated lesions. Those patients can also be potentially considered. But honestly speaking, if you have a prolonged disease and you have disease of running in years and you have unfortunately accumulated significant disability, the role of stem cell therapy is probably negligible, and it is clearly not recommended. However, said so, each patient will be screened appropriately, discussed with, and based on a clear suggested potential experience in the guidelines and recommendations, you'll be selected as a potential candidate. But yes, I do say that this is an appropriate strategy, and in centers where you have methodical protocols for doing bone marrow transplant, and if patients are failing two good therapies which are thought to be very effective, they should be offered this as a potential treatment.
Thank you, Dr. Rohit. Thank you. Stem cell therapy is definitely there, and has to be, basically, it has to be done under a supervised. That center should be supervised, having a proper hematologist, transfusion medicine specialist, as well as the neurologist, and they'll have to have a teamwork which has to be there, and it has to be done. Because of the shortage of time, I just want to, there are a lot of audience questions. A few things have already been discussed, especially about the progressive MS. I think it was already discussed. And one of the questions is on the usage of ocrelizumab, about age factor. One of the question is whether after 60 years of age it can be used. Yes, it can be used. There is no problem. Not taking any individual questions into discussion. I think one of them have asked about the usage of dimethyl fumarate. So it is not that it can't be continued. So just before planning for pregnancy, usually 2 to 4 weeks it can be stopped, and then it can be planned for pregnancy. And there is no problem if a male patient is taking dimethyl fumarate. It is only teriflunomide which is having the issue. So before we try to wind up, I would like to take up just two questions, I think, which is very most important. One is on the vaccination and about the usage of nutrition. So Dr. Rohit, if you can just talk about the vaccination. Dr. Rohit?
Okay, sorry. Yeah, so I think there was a question about HPV vaccine, which was mentioned. So as per the recommended guidelines of vaccination, which is human papilloma virus is an inactivated recombinant vaccine, it is recommended that people who are, especially women and men with MS, who are likely to receive, more effective treatments like alemtuzumab, or for example, one of the Fingo or Siponimod, cladribine, or most of these anti-CD20 drugs, it is recommended that should be considered. And it is also considered that they should have a complete immunization, which is, it should be ensured that the immunization is complete. So they can definitely discuss it with their treating doctor or their gynecologist in case they want to have a word with the gynecologist as well. But human HPV vaccine is generally considered safe and can be given because it's also a recombinant vaccine.
And even the varicella, I think we should not forget varicella, because a lot of these medications may activate varicella. So these vaccinations should be definitely completed before you start, and a gap of at least 4 weeks. If you're on rituximab or Ocrevus, give a gap of 4 weeks after the vaccination for the antibody response to build up, and then take the DMT.
Dr. Dheeraj, a lot of questions are there on about nutrition. A few people have asked specifically about poultry, B12, vitamins. You already spoke on vitamin D. If you can just stress about the other nutritional aspects.
There is nothing as of now. I'm not aware of specific. There have been, these are nutritional trials have not proven. There have been some controversies which have built up over years of different things like, taking gluten or taking dairy. There is no such thing as being harmful in MS. It all depends on your own personal preferences. Poultry can very well be taken. The most important thing that we emphasize is a healthy, nutritious diet, which means you should have adequate, the same thing which you tell for people for NCDs or strokes, the same holds true for MS. That's an NCD too. And you are simultaneously at risk of developing cardiovascular disease as the general population, and even more so in MS, because the exercise tolerance or exercise capability may go down. So it is very important to take nutritious food, less of fat, more of green vegetables and fruits, and exercise as we usually tell them. So the recommendation remains the same. There is no such specific diet recommendation in MS. It should be a diet which does not let your weight get gained. So because that is going to be very important in the long run. Weight gain has been associated with worse outcomes in MS. We should remember that. And it's not just for cardiovascular morbidity. It separately has effects on MS. So weight gain should be avoided at all costs. And for that, you need to take healthy, low-fat diet, less of fats, less of fried foods, more of green vegetables. And rest is all your personal preference. You want to try intermittent fasting or something, that's personal preference. We don't have studies as of now which tells us whether these do better in MS. But definitely, yes, if you lose weight, you'll feel much better in MS.
Thank you, Dr. Dheeraj. I think the gut and brain, there is a lot of talk on that. A lot of studies are happening to see what is the relation between what we eat and what is our brain health. I think future studies will show, apart from what Dr. Dheeraj said about any disease modification or nutritional modification which can be there. Before we close, I just want to take one more question which has come up. One of them is about the remyelination treatment. Yes, there are a few medications which are under investigation, still not proven about remyelination treatment. And one of them have also asked about the level of research. I think at this point of time, I would request Dr. Rohit if he can just bring about his about the registry which is being maintained, the national registry. So that may help us in understanding. Dr. Rohit.
Yeah, thank you, Netra. I think most of the colleagues here right now are part of this registry. Dr. Netra, Dr. Dheeraj, Dr. Gorthi, and we have this Indian Multiple Sclerosis Registry and Research Network, which is funded by the Indian Council of Medical Research, which actually started initially and in 2020 as inception, and then 21 centers were activated. So we've been running this registry for about 4 years now, and we're collecting information from all across the demyelinating spectrum, including MS, which is the largest group, and the similar diseases like NMOSD, MOGAD, other forms of demyelination which do not classify into either of these subtypes. So the aim of this registry is to collect information across all centers in one homogenized way, and we do it at a baseline, and then we, at each 6 months follow-up, we inquire from the patients about how they have been. We're also collecting data on MRI scans. So the aim of this is to have a fair idea about how our population is, and does it compare to the West? Are we different in our disease responses? What kind of medications we use? Are low-cost medications as effective as one which are more cost and are currently difficult for people to afford, for example, rituximab? And also to look at how pregnancies do, how patients do during their pregnancy, what are the exposures, and so on and so forth. So I think with a lot of input from all our colleagues, and we working together towards a simple goal of understanding the different disorders and the behavior, and hopefully we'll come out with some important conclusions which will help us shape our future studies, as well as help guide our patients with their questions during their visits. So I think that's, in summary, what we are trying to do with this registry.
Thank you, Dr. Rohit. And I think there is a very important study which is being conducted, and Dr. Rohit has been instrumental in starting up with this. So there are many questions. One of them have actually appreciated both Dr. Ayush and Dr. Rohit. And there are a few questions which are talking about remyelination. I think because of the wanting of time and already many things have been discussed, will not take more questions. I just, this webinar has been initiated in the, because of World MS Day, which was yesterday. So we have been conducting this as part of the IAN autoimmune subsection. So before we close this session, I would request the panelists to give a short some message from you all. We'll start with Dr. Singhal, sir. Sir, if you can give a short message to our attendees.
Well, thank you, Netra. I think it's been a good learning experience for me, and I think the panelists, including yourself, Dr. Dheeraj Khurana, Rohit, Gorthi, Dr. Ganraj, Dr. Ayush Agarwal have dealt the subject extremely well and taken all necessary things, including the nutrition and vaccination, pregnancy, which are very important issues in the management of multiple sclerosis, quite apart from the drugs. And I think I'm quite sure that the registry initiated by the effort of Dr. Rohit and Khurana and others will definitely provide answers, because I think there must be some genetic variation in India. I'm not so sure that we all react the same way, because I think although we are being guided by what has been told in the West, but whether once we have our own data, we'll know how the patients are behaving and doing. And here, of course, the role of the patient also becomes extremely important, Because, for instance, I have a few questions, For instance, the use of cyclophosphamide is a very cheap drug, not for the young girls, but of course for the men. There's also the use of, say, mitrexentron, These drugs are totally discarded, probably from side effects and all that. But I'm quite sure, the turmeric, for instance, I'm quite sure there must be immune enhancers in the diet that we have followed in the Ayurveda. So maybe I think Rohit will probably look into some of these things along with his colleagues, and we have some answers on as well. Thank you, Nitra, for asking me to say a few concluding remarks.
Thank you, sir.
Rohit, and you will have more to say.
Dr. Rohit, thank you, sir. Thanks a lot, sir. Dr. Rohit?
So I have just one thing to say, that to all the MS warriors, and that I think we are at a very different time point in medicine, and we are in a very advanced phase of understanding this disease, with lots of treatments, with excellent efficacy, monitoring capability, understanding their potential adverse effects, what to monitor, vaccination strategies are more clear. I think I'm very positive that majority of the patients are going to do very well, and they should stay positive, and they should always think that, okay, fine, there is an illness. I know, I understand, and that's what Netra said, that initial reactions are, of course, a bit concerning. But I think we should take it positively, and there is nothing that we want you to hold on to, other than, of course, smoking, that we don't recommend in MS because of the noise it carries. But as Dheeraj said, eat whatever you want, but stay healthy. And as we recommend to any other person, to lead a very healthy and happy life. So I think that's from my side.
Thank you, Rohit. Dr. Dheeraj?
I would just reiterate, and this World MS Day, I think the theme is My MS Diagnosis. I was just looking it up short while back. So, which reiterates that the MS diagnosis is prime, because early diagnosis is important, and the way we can do that is, spread the stories. People need to share their stories with people. People with MS need to share their diagnosis with others, so that people can seek early diagnosis. The access to treatments is getting better, access to diagnosis is getting better. And not only that, we should also spread awareness among physicians, because as we've discussed, there has been a lot of advancements even in the diagnostic arena. We have early diagnostic measures. We've been discussing that because of the new MS criteria also, which aims to diagnose MS even at an earlier stage than what we were doing a few years back. So in line of that, what I will just say is people need to share their stories with other people, so that people become aware of the symptoms and seek help much earlier, as now we have even faster and more effective tools to diagnose and then treat you appropriately.
Rohit, would you take up with the insurance companies so that the patients can afford the treatment?
Sir, actually, very recently, when we had this MSSI program, where they had also, and Dr. Netra was also there, and they had also invited colleagues from the administration as well as from the ministry and from the disability ministry as well. there was a lot of discussion about insurance policy, and we did raise we also raised the awareness about the need to promote more of essential medicine list drugs that are being recommended even by WHO, and the insurance companies. There was a discussion. There was quite a detailed discussion about that, in which I'm sure the MSSI will take it forward in support of the patients. So that is going to definitely happen. But I'm also hopeful that in due course of time, there would be generic availability of other agents also as time passes, and we will have more armamentarium of relatively cheaper options, and we still have them. So hopefully that should be also a part of the progress, as you rightly said, regarding insurance coverage for most of the patients.
Thank you.
Thank you, Rohit. Thank you, Dheeraj. Dr. Gorti, sir, over to you. Doctor.
What I wanted to say is that, yeah, we have made a lot of, we've seen a lot of advancements in multiple sclerosis treatments and things. But most of the trials say it is prevention of annualized relapse rate, which cannot be extrapolated to individual patient. So my request is that don't promise moon to them, because every treatment has its own limitations. And if you see, most important thing is the prevention of disability or improvement in disability, and very few drugs are doing that, except and those drugs are to be encouraged. And for me, that natalizumab has worked, and now ocrelizumab. So, and whatever quality of life we can improve, and we should try to do that. And dalfampridine and gait improvement and bladder issues. But many people, we have to explain to them what are the effect sizes of our treatments. We should not mask them, and we should real picture of how effective they are. And most of them are 30 to 36%, except some are only 68%. That too, they prevent annualized relapse rate. And so in this, we should be very judicious in our recommendation of the treatments, and we have to give choice to the patient to choose what they want. Thank you.
Thank you, Dr. Gurti. Thank you. Dr. Ganaraj? I hope Dr. Ayush joins. Dr. Ganaraj?
Everyone has told there has been a lot of advances in the treatment of multiple sclerosis, and this year's theme, as it shows, that it is my MS diagnosis. So currently, as previously it was thought, once it was diagnosed, previously it was that was the end of the story. Now it is not like that. There are many advancements in the treatment, and there are many therapies which are available. So not only the treatment, in addition to that, multidisciplinary care, like with the psychiatry, with the rehabilitation measures, with the lifestyle modifications, we can definitely treat and address multiple sclerosis issues very clearly.
Thank you, Dr. Ganaraj. I think we lost Dr. Ayush. If he comes, we'll ask his this one. I just request all the panelists to switch on their video for just a quick single, sir. Dr. Gorti.
Yeah.
We'll conclude with hope.
Thank you, sir. Sir, if you can just switch on your video, sir.
Great. I think well conducted. Thank you, Netra, Rohit. I think you've done extremely well. Dheeraj, of course, a lot of experience. So also Gorti and Nagarajan and Ayush Agarwal. I think great. Thank you very much indeed. And we conclude with great hope for patients with multiple sclerosis.
Thank you, sir. I think you summed up very nicely about the hope aspect. Many of them could not join mainly because of the many concurrent other commitments which most of them had. So I thank everyone, the panelists, Dr. Rohit, Dr. Singhal sir, Dr. Dheeraj, Dr. Gorti, Dr. Ganraj, Dr. Ayush for being here today and helping us conduct this IN autoimmune subsection meeting. The theme was because of the World MS Day, which was held yesterday. Thank the IN to give us this opportunity for us to conduct, and so that we'll be able to touch base with our MS warriors. And really thankful to all the attendees, the MS warriors and others who had joined us in great numbers and made this success. Finally, thanks to Asmita, the digital team, for helping us have a seamless, very nice webinar today. Thank you, everyone.
Thank you, ma'am. Thank you,
Thank
Dr.
you.
Shingal.
Good
sir.
night and have a, sweet dreams and good night. Thank you.
Good night. Sir. Good
Thank
night.
you, sir.
everyone.
Thank
Good
you, everybody.